Out to David Rankin, who is the Director of Clinical Governance and Informatics at Cabrini Hospital. And he's going to give us a little talk about using the VASM data for quality and safety standards. So over to you, David.
Thank you very much, Philip. And thank you for the opportunity to present. I have taken a slightly tangential approach. Rather than focusing exactly on how Cabrini uses the VASM data, I'd like to particularly pick up on how Cabrini is trying to implement standard 1.28 in sharing data with our clinicians, but more importantly, look at some of the challenges and issues that we've identified in this process. I guess the start is that hospitals receive data from an enormous number of organizations, and each organization customizes or creates their unique data presentation, which makes the comparison of data between agencies extraordinarily difficult. I suggest that there's no end to the creativity of a data science given access to health statistics. I don't know which is the best presentation of data. And we've been interested in exploring some of those. There seems to be an almost consensus that the funnel plot is the gold standard. Lots of organizations use it. It's fiendishly difficult to create. The data gets extraordinarily unstable when you get down to low volumes because you can't really define variance. And in most cases, it's extremely hard to case mix adjust. And so when we developed a funnel plot similar to this for our surgeons doing lap chole, these surgeons were the ones that tended to get the subphrenic abscesses, and these were the surgeons that tended to operate on younger, healthier, skinnier patients. It's very, very hard to case mix adjust clinical data. So, looking at the VASM report, Cabrini is proud that VASM identified 28 surgery-associated deaths at Malvern Hospital. 4 of those were identified as having clinical management issues, 3 better surgical options, and 1 delay in surgery. The first question we ask is that Cabrini actually had 45 surgery-associated deaths. Were the 17 surgery-associated deaths that were not considered by VASM the bad ones, and so were not reported? We don't know. The second thing is that we undertook 21,000 surgical procedures at our Malvern Hospital last year. 11,593 of those stayed overnight. 675 of those 11,500 patients were recorded as having a hospital-acquired complication, a total of 951 complications. 304 infections, 125 surgical complications requiring return to theatre, 26 VTEs, 24 GI bleeds. So I'm not sure that the 28 surgical associated deaths that VASM reviewed really reflected the poor outcomes. Maybe the 28 deaths reflect safety, but I'm not sure they reflect quality. We provided 551 transfusions to our surgical patients. 302 of those surgical patients exceeded the high trim point for their DRG. So this is a complex formula for each of the DRGs to work out when the health funds effectively stops paying or starts paying on a per diem basis. And so 302 of those patients exceeded their high trim point, which is well above the average or expected length of stay. And there were 603 net calls for those 11,500 patients. So I have some concerns that VASM data provided to private hospitals may give us a false sense of our quality. Private hospitals are very lucky in that we can select our patients who are not likely to die. and we can transfer patients out to the public system if we have concerns that they may die. These indicators for their selected MBS code or group of codes. And we highlighted those that statistically represented variance from the mean. Craft group and the craft group's percentage, and then a graph matching theatre time and length of stay. We also gave them a breakdown of their contribution, total profit and average profit. Another big learning curve for us. This was quite confrontational, and so we no longer share the average profit. It is dependent on a large number of issues. Many of those issues are not under the control of the surgeon, and we never made it clear what the implication was for, say, surgeon 7, where on average, each of the patients that he admitted cost the hospital $1,271. And that became quite frightening, as that surgeon said, "Are you going to ask me not to operate at your hospital anymore?" And so we've pulled that. Some of the learnings that we've gained is, first of all, trend data is really important. And so we now present data trends over the last 5 years for the individual procedures that the surgical craft groups are interested in, including their complications, average theatre time, percentage same day. This year, we've been presenting trend data on the impact of COVID, and you can see the surgical lockdowns in Victoria had a dramatic impact on surgical volumes. Sleeve gastrectomy dropped to 0 during a lockdown period. Not a big impact on lap chole, although ENT surgery dropped very remarkably. It hasn't recovered. So COVID's had quite a significant impact. We still use the same outcomes report, although we've added a couple of more clinical indicators, transfusion and met calls. There's a lot of debate around operational clinical indicators, like average time to surgery or discharge before noon. Are they really outcomes indicators, or are they process indicators? We leave them in at the moment because they're important to the hospital, and we like to share them with the surgeons. What are some of our challenges? I think it's very important to define the purpose and the consequence of data extraction and sharing. It can be very intimidating and confrontational if surgeons don't know what the organisation's going to do with the reports, particularly when they get down to named individual surgeons. And so I suggest that each organisation really needs a signed and defined agreement about what the purpose of the data is and what the consequence. If you're a consistent outlier, is it going to impact on your credentialing at that hospital? Will the theatre manager find out that you are an outlier on a clinical performance indicator? And is that fair? Will that bias your access to available theatres or rostering on call? So a very clear definition of what the purpose and the consequence of the data and the reports are. One of the principles we've strongly adopted is that the data is a screening tool. We don't know what it means. It's not diagnostic. We cannot highlight who the good doctors are or the bad doctors are, but it is a useful screening tool to allow doctors to reflect on their outcomes and their data and see if there are opportunities to enhance their practice. Defining the clinical indicators, I think, is a real challenge. Is transfusion a real clinical indicator? On the whole, ENT surgeons or ophthalmologists never transfuse. Orthopedic surgeons undertaking major joint replacements often transfuse, but that transfusion may not be a consequence of poor practice. It may in fact be good practice. Similar to admission to ICU. Is that a good clinical indicator? I don't know, but I think it may be a reasonable screening tool. Selecting data. Surgeons usually request data on the basis of NBS codes, but often patients are better collated on the basis of their diagnosis. So can you highlight all the patients that I operated on, David, with metastatic breast disease? Maybe a better patient selection criteria than patients that had a mastectomy. Selecting data by age or by specialty group. What constitutes meaningful variation? How different from your peers should you be before your variation gets highlighted? And that's particularly an issue with very low volume surgery. The frequency of reporting, should it be annual, quarterly? We've normalized most of our data reports quarterly, although for less frequent procedures, we will review them on an annual basis. Interestingly, I'm keen now to start asking surgeons to comment on abnormal indicators at the time that the indicators first reported. So I get riskman reports that come through every morning on the patients that return to surgery. And so I've started with the endorsement of the surgical executive group, writing to the surgeons and asking a series of just simple questions. Were there patient factors that led to the return to theatre? Were there technical issues associated with the return to theatre? Have you undertaken root cause analysis, open disclosure with the patient? And given the case, have you reflected on it, and are there any pertinent points that you think would be worth sharing? And I've been delighted with the very high response rate and the level of reflection that many of those surgeons have shared. Issues around distribution. Again, I naively thought that if I put up the complex dashboard on a portal and allowed the craft group leaders access to that portal, they would all jump on it as soon as the data was available and have a look. Clearly that doesn't work. I was in cuckoo land. We've then started distributing Excel spreadsheets. They get better uptake, but most of the craft groups have said, David, can you put together a short PowerPoint presentation highlighting the individual cases that we should review? And so for the groups now, I distribute a PowerPoint presentation on a quarterly basis. Questions of whether that is best done in a hard copy, distributed to all of the surgeons before, or in soft copy. Should it be push or pull? So should surgeons be able to go onto a portal and draw down their presentation? I've found most surgeons don't do that. They really rely on it being pushed out to them. Questions around whether the data should be distributed individually or in groups. At this stage, we found that distribution in groups is more effective. The craft group leader can then moderate the data before it's distributed to individuals. Engagement and trust is a really key issue. We, in our evolution, have demonstrated that some of our data is very poor, and we've gone back and highlighted that. We've engaged expert advisors. We've tried to work with champions in each of the craft groups who can help their colleagues understand the data. We've tried to maintain open dialogue as we've iterated and developed our data. Issues of disclosure. Who gets access to the reports? And as I mentioned earlier, at Cabrini, operational managers do not get access to clinical reports. They're held within the clinical team. Encouraging reflection. And I guess this goes to issues of engagement. And in the private sector, engagement in craft group meetings is extraordinarily variable. We have some craft groups with 25 or 30 members, and we'll get 3 or 4 surgeons attending the peer review sessions. We have other craft groups with 30 or more members, and they'll get 20 or 25. I must say Zoom's been a godsend. The physical attendance at physical meetings was traditionally low, but our attendance in Zoom meetings has been delightful. And determining success. I am not sure how to determine success. I take great encouragement when I get emails back from craft group leaders or from individual surgeons reflecting on their data or asking comments or can I see this file. But I must say with over 800 admitting specialists at Cabrini, I'll get maybe half a dozen emails in any quarter. So it's extraordinarily hard to determine whether we're successful. My last reflection is then that clinicians determine a patient's outcome, largely a patient's experience and a patient's cost. It's the clinicians that determine when a patient goes home. It's a clinician that determines whether or not the patient needs to come to the hospital. So bridging that gap between data specialists who see no consequence in the data that they prepare and often can't interpret the data, and the clinician who we're asking to reflect on their practice as a consequence of that data is an extraordinary challenge. And I would welcome any feedback, suggestions or enhancements to the processes that we can use to continually improve the outcomes for patients attending Cabrini Hospital.
Thank you very much, David, for that fascinating data fest. Amazing amount of detail you've got there, and I think certain geeks amongst the surgical community would love it. Some may, as you say, not respond very well to it, but I think it has to be put out there now, and increasingly it's going to be probably available to everybody. I know the VASM team was sort of having little kittens with one of your first slides there about the number of cases that Cabrini have been reporting back on. I think there's probably two reasons for the disparity at the moment. We may be waiting for second line assessments or for first line assessments before reporting back. So there is always a delay in things coming through from that. And we're also very dependent on the stuff being reported to us in the first place. I think Cabrini is very good, but some health services, we do have concerns that we're not necessarily being told about all of the deaths, which I'm currently trying to chase up. But that was a brilliant talk, and I know it's generated quite a few questions, which we'll go through very shortly.